start, what I'm wanting to do is talk for a little while about mental health, because it's really hard to go, okay, let's do a mental health assessment when, you know, you really need to have a solid understanding really of what mental health is and why we're actually doing this mental health assessment. So just wanted to tell you that 16 million Australians aged 16 and 18 years, almost half have had a lifetime mental health disorder at some point in their life. And it's supposed to be about 1 in 5 people over a lifetime will have a mental health disorder. So people with things like schizophrenia and bipolar disorder, which I'll talk about later, that's about 2% of the population. But the major disorders such as major depression, adjustment disorders, which are the things that you see, are really, really prevalent. Like there's about can be up to 75% in general hospitals of people with a major depressive disorder or an adjustment disorder. So a question for you before we even start, what do you think the leading cause of death is for people who have, or people within mental health services, or people who have a severe persistent mental illness?
Suicide?
I'm not going to... No, that's fine, yeah. Yeah, no, good, thank you. That's why I asked the question. I asked the question. So, yeah, who else would think it was suicide? Yeah, others? Usually people say suicide. Even, sorry? Cardiovascular, yeah. Even if you're asking mental health staff, they'll tell you suicide. So you're saying cardiovascular, any others? Lung cancer? Liver disease? It's the highest is, I'll go to you. So 6% is suicide. 27% is cancer, all sorts of different cancers. 22% is the cardiovascular. And then you've got GIT and liver, smaller. 8% is respiratory. So yeah, you're going to get a lot of respiratory things because people are smoking, and I'll talk a bit about that. But often people are quite surprised at how people die. And what is also happening within mental health is that people are dying 20 years younger, around 20 years younger, and they have about 20-year high morbidity rate as well. So the people in the project that Karen and I were seeing were mainly around 50 years old. So even though the palliative care population was generally much older than that, the people that we saw with mental health problems were around 50 years old. So it's they die about the same age as the Aboriginal population, if not a bit lower. So increased prevalence of cancer in people with mental illness. There's now been a lot of research coming out about it. There's higher rates of breast cancer and digestive cancers have been reported for people with schizophrenia. It's been digestive cancer has been associated with high consumption of alcohol. A lot of the people that have mental health problems, there's also really high comorbidity with drug and alcohol problems. And breast cancer increased because of the increased prolactin levels with the use of antipsychotic medication. And I don't know if you're aware of this, but antipsychotic medication can also do things like lead young men to lactate, lead women to lactate, that kind of stuff as well. But yes, they're thinking that the high prolactin levels are causing the cancers. Cardiovascular disease, which is what you were talking about before, 2 to 3 times higher than the general population. Women, again, have a higher rate. And it's things like, as you would know, it would be things like obesity, smoking, not eating properly, not getting enough exercise, all those contributing factors. And when someone has a mental illness, it can actually be really hard to get the energy together to actually get up and make yourself a good, dinner and go out for a walk or whatever. And hyperlipidemia is a risk factor for developing cardiovascular disease. Respiratory disease, and most people that you see that have a mental health disorder have smoked or are continuing to be smokers. Like people that we see in mental health services, the vast majority of smokers. The people we saw in the PAL Care program, the vast majority, I think nearly all, had been smokers, but a lot of them had actually stopped. So in mental health, and I think it's much higher than that, 68% of men and 54% of women are daily smokers. I think it's as high as 85, 90%. And there's an increased rate of bronchitis, emphysema and chronic airways disease. I just want to talk a little bit about, before we actually go on to assessment, about the kinds of put it in a collection of mental health disorders. So the types you may see in mental health, we generally divide it into categories, 2 categories. And the major category that I work with and mental health services work with are the psychoses. And they're the ones I was talking about before, which is 1 or 2% of the population. The major ones that you will see are the non-psychoses. So the psychoses are things like schizophrenia, and I'll talk about that briefly, mood disorders such as a major depressive disorder, and bipolar disorder. And the non-psychotic ones are anxiety disorders, so you probably see a lot of anxiety disorders in your practice, obsessive compulsive disorders in your practice, phobias, personality disorders and adjustment disorders. And adjustment disorders are, it's like, having quite a severe trauma when you're told you're going to be, dying. So there's a lot of people with adjustment disorders, and also all the lifestyle changes that go with that as well, and the losses that go with that. There's what I've seen is many, many adjustment disorders within Palcare. So just really briefly, and I don't want to, to teach you how to suck eggs, just so that I know that you know what schizophrenia is, because that's what we're going to be talking about a lot, is that it affects the functioning of the brain, and it affects people's ability to think, act and feel. So a person with schizophrenia may have things like hallucinations. The majority of hallucinations I think that people have are auditory. So they're hearing voices, and the voices might be telling them, they might be friendly voices. Sometimes people love their voices. They might be friendly voices who are their friends and keeping them company, but often those friends keeping them company voices will change into things that start to tell them really quite nasty things about themselves, like you're a bad person, you're an evil person, you don't deserve to be alive. In palliative care, it could be things like, well, you got this illness because you were bad. So the voices can actually start to contextualise around what's actually happened in somebody's life. So, you've become ill because you were bad. You've become ill because this is a punishment from God. God's punishing you. That's another one that I've heard of for people that have actually got a life-limiting illness as well. Delusions. Delusions are things that society they don't hold to be true, and are not within their cultural context as well. So the people that Robert was talking about from that church, they wouldn't be suffering any delusional stuff, even though the majority of society might not see what's going on with them as truth. But me thinking that my skin is blue could be a delusion. My thinking that my son is really unwell could be a delusion. My thinking that my husband is poisoning me, it probably be a delusion. So those, I hope he's not. So, yeah. And thought disorder. And I think thought disorder is the hardest one, and that's the thing that you need to be looking for within the mental health assessment. And it's really, people can't get their thoughts together. It's quite a hard thing for me to explain, because we normally think in a quite clearly constructed way, whereas someone with schizophrenia, and they may just have the thought disorder, their thoughts get really jumbled. So you know how we think in a kind of a linear train, their thoughts could be coming from all over the place. So it's much harder for them to actually do something like a normal thing, like go down and tie up your shoelaces, because another thought might be coming in, or so it's very, very jumbled. And that's the reason I've got that photo up there, is that someone who has schizophrenia, they painted that, and that's what it feels like, that kind of jumbled mirror-like sensation, or a broken mirror sensation, whereas the thoughts are kind of jagged and all over the place. I often put artwork from people who have a mental illness into my presentations, because it is usually very, very meaningful for people who have severe persistent mental illness, and often they're brilliant artists as well. Just as an aside. So bipolar disorder is another one of the major disorders, one of the major psychotic disorders, and as psychotic disorders are the ones where things that are happening are out of reality, basically. And a bipolar psychosis appears as part of a general disturbance in mood. It can be characterised by highs and lows of mood. Someone who's extremely elevated may think that they have really special abilities. Often you'll see people within a mental health system who are hypermanic, is what we call it, and they might think that they are brilliant on the stock exchange, and it can be a real problem because, especially now we've got the internet, before you could kind of contain that, but you know, they may go out and blow all their money. They may apply for jobs that are way beyond what they can do. They may, and it can get so bad that I've known someone who thought they could fly and they've jumped out of a building. You know, so it can be very, very serious. The delusional stuff can be very serious, and it's out of their normal realm of functioning.
Sharon, just a question of interest.
Sure.
It might be quite difficult for clinicians working in mental health sometimes to diagnose whether it's bipolar or schizophrenia.
It is initially.
The psychosis.
Yeah. One of the things in mental illness is often diagnoses aren't clear-cut.
Sure.
And you can have a thing called a schizoaffective diagnosis as well, where there's elements of schizophrenia. There's things like the hallucinations that are happening. Somebody is actually having auditory hallucinations, but they're also having a manic episode where they're getting really, really agitated and high. And I'll talk a little bit more about, you know, that high agitation as well. And yes, it can be very difficult to diagnose, and diagnoses change over time as well. I mean, you might think someone has a major depressive disorder, and they might hit 40 and suddenly have a manic episode. So then they've got a bipolar disorder. So it isn't clear-cut at all. Sometimes you're lucky to have a clear-cutness, but most of the time, no. Especially in the early phases with people. Yeah. So major depression. Major depression is a sustained sad mood over a period of time, feelings of worthlessness, hopelessness, guilt, reoccurring thoughts. So in palliative care you can have, you know, things like reoccurring thoughts of when people get really, really depressed is, I deserve this illness. I'm a really bad person, so, you know, this is why this has happened to me. It's similar to the schizophrenia. The person with schizophrenia is hearing the voices, but this person may be just having these very ruminating thoughts about what a bad person I am, how hopeless the world is, how bleak the world is, and often they'll describe it as the black cloud. You know, or walking through cotton wool, walking through black cotton wool is what their world is like. They can't make decisions. It's really hard for people to kind of work out what's the best thing to do. And we have things called vegetative symptoms in mental health, and they're things like insomnia or disturbed sleep, changes in weight, changes in appetite, fatigue, energy loss, loss of motivation, inability to concentrate, loss of pleasure, diminished sex drive, and they may have psychotic features. So someone who is severely, severely, severely depressed may in fact start to hear voices, similar to someone who has schizophrenia. The thing is, in palliative care, when you're doing a mental state and you're looking at somebody's vegetative symptoms, how many of those are affected by their illness? Yeah? So it starts to make things a little bit tricky. So in the mental health examination, you may, and we'll talk about this again, you may see things like poor grooming. Now, hey, that might be because I'm feeling really sick at the moment. Or ill-fitting clothes. I might have lost a lot of weight because of the cancer. Poor posture. So the things that you would normally look for in mental health are a bit different once you hit palliative care. So it makes diagnosis of a major depression a bit more difficult. But the key symptom, I think, in palliative care and with people who are sick in general is things like are they still getting pleasure in life? You know, are they still looking forward to their grandchildren coming? And one of the things I might ask at the moment is, what are you looking forward to at Christmas time? Is there something they're still hoping for? You know, so if they're saying, nah, It's all bleak. Then I'd start to be really concerned. So I'd maybe see them a couple of days later. If it's still the same, they're not looking forward to anything. They're finding no pleasure in their food. I think is a particularly, if they can eat, but they're eating and they're finding no pleasure in that at all. It's a sign again that there's something really wrong as far as their depression levels go. So what I'd be looking at is severity of the depressed mood, how long it's been going on for, whether they have any interest or pleasure, whether they have, in palliative care, is there a sense of hopelessness or guilt? I think that's another telling sign. Are they feeling like they're worthless? Are they a burden? And is that a continuing theme throughout? And is there any presence of suicidal thoughts? And I think the suicidal thoughts go a bit deep. I think usually in palliative care, people who are in pain, people who don't see that there's any future, may go through a period of, I'd be better off dead. I'd be better off without my family being with me. So how do you tell the difference between somebody who's just having those very, very fleeting thoughts about suicide to somebody who is actually contemplating it? And we'll talk about that a little later as well. But I think that's really important. And I have seen palliative care nurses do this beautifully. I've seen palliative care nurses do it much better than mental health nurses when they're talking about things like the person feeling like they're a burden and the palliative care nurse just coming straight out. And on many occasions I've seen it, have you been having thoughts about suicide? And seen them do it beautifully.
It's very challenging. I find this very useful. It's incredibly challenging because depression is one of the things that we encounter the most in palliative care practice. And in palliative care is also the other concept that gets flagged is demoralization. But as you said here, one of the things that a clinician looks for in terms of is it really established depression?
Isn't it
where you need to take, a different course of action?
Yeah, whether they may need some antidepressants, what would be useful at this point in time? Yeah. As a mental health nurse, this is the hardest thing we deal with as well. So a diagnosis of major depression. So they can often be tearful and accompanied by social withdrawal and loss of motivation. And that tearfulness can, if it's going on and on and on, these patients may feel they're unable to control their negative feelings and feel that that's beginning to dominate their world, like the black cloud is beginning to dominate their world, basically. So depressive in medical settings, as I said before, medical settings, the odds are 3 times greater that a patient will be non-compliant with medical treatment recommendations. So it's really important that if you suspect somebody has a diagnosis of depression or a depressive illness, that you actually do something about it because it helps with compliance and helps with their overall treatment. The odds are 3 times greater that a depressed person will be non-compliant with medical recommendations as well. So depression and cancer. Up to 66% of people with cancer experience long-term psychological distress, so that's really high. Up to 30% experience clinical anxiety problems. The prevalence rate for depression is about 20 to 35%. Significant psychological distress has been reported in 43% of patients with lung cancer, so it's really high. And is there anything else? I'm just going to move on now to the actual mental state assessment. But is there anything else any questions about mental health disorders in general before I move on?
Well, anxiety is another major.
It is. And
I don't know whether it fits into other categories.
No, I think it fits in beautifully there. Like depression and anxiety, and go quite hand in hand together. Maybe a lot of times when somebody has a depressive illness, they also have anxiety as well. So what you're going to be looking at with someone who's got a depressive illness is how much that anxiety is affecting their life as well, and that then you will work your treatment out from that point. You might choose a different antidepressant, something that's much more sedating than something that's going to actually lift their mood up a bit, because antidepressants kind of have those 2 different functions. They may be sedating or they may help elevate the mood, and if somebody's anxious, that actually might make them more anxious. So you're going to be treating them in a different way. But certainly I think the anxiety, especially in people with physical health problems, when people get depressed, there's often an anxious element about it as well.
The incidence also, Sharon, the incidence of depression in the non-malignancy population also, 35 to 40% now of malignancy. The elderly,
really high.
Often they are in a myriad of agents and they're actually still very depressed. Although I think it's very relevant.
The last article I read was saying up to 75% of people with physical, that are in hospital, whether it be, they're in palliative care or aged care settings, have, some depressive symptoms or an adjustment disorder with depressive symptoms. So it's very, very high.
I think sometimes it's difficult to distinguish between Axis 1 and Axis 2 diagnosis because the clinical presentations can be quite similar, and what you might perceive as a depression might actually be part of a personality disorder, and how you kind of tease out the different features is often difficult in the setting of advanced illness. Absolutely.
And I think that gets back to the whole, in mental health all over, it's very difficult to tease out those things. But does everyone know what Axis 1 and Axis 2 is?
The difference between a major depressive disorder, I thought your graph suggested the psychosis.
It's Axis 1 and Axis 2 are slightly different from that. An Axis 1 diagnosis is basically all the things I was talking about, except personality disorder. So Axis 1 is schizophrenia, bipolar disorder, major depressive disorders, anxiety disorders, adjustment disorders. They're all Axis 1. Axis 2 is mental cognitive problems usually associated with mental disability, drug and alcohol problems and personality disorder. So, and yes, so they're different. The axes are different. But it is difficult to tease out the difference between when somebody has when someone has a personality, to tease out how much of that is depression and how much of that is a personality disorder. I would tend to very much sit on the side of it's a depressive illness and work with that, because people with personality disorders, and I'm not going to talk about them too much, it's a whole other topic on its own. People with personality disorders often get left aside in emergency departments and left aside in mental health places because they're so difficult to treat. And they may have a severe depressive disorder as well. So there can be comorbidities within mental health. Somebody can have schizophrenia and have schizophrenia all their life and be managing it very well. They may come into palliative care and develop a major depressive disorder. So you can have those comorbidities. So yeah, people with personality disorder can develop a major depressive disorder as well. Yeah. Any other questions, comments? It was good, thank you. Okay, and as we go on, if you have any thoughts, ideas, comments, questions. So the presenting complaint, and I think really this is what we do in a mental state examination. Now, people think that a mental state examination is me really observing somebody and coming out with this mental state examination, but really what I'm doing is asking them lots and lots of questions, lots of kind of formatted questions about what's happening with their life at the moment. And so we're talking about why are you here, why have you come to see me? So that's fairly typical what happens in a medical setting, why have you come to see me? What are your complaints? How do they make you feel? What are you most concerned about? So I'll be eliciting all this information at the same time as doing a mental state examination. So while I'm listening to what they're telling me about what their presenting complaint is and what they're most concerned about and how things make them feel, I'll be doing the mental state assessment. And you clarify any kind of how this happened in time, were there any precipitants. But I think it's really important when you're doing this is you're doing what Robert was saying this morning, and you're looking at, not only, because this is very medical, this is what people do, but I think you add the nursing and talk about what is it that you're hoping for. You know, what do you hope for your future? What do you hope for what's happening in your world? What do you hope's going to happen with this complaint that you've come with? Because that's the point that you start to work from. What direction do they want to go in? And I think that's what adds the nursing element to the mental state examination. But I think it's really important to be curious, but not too intrusive. And again, it gets back, and I was really pleased you did the talk this morning, it gets back to your therapeutic use of self, you know, that therapeutic relationship, that, you know, you being really curious about what's happening with that person, but you're also developing that sense of trust, you know, and trying to instill hope, all those things that you do as palliative care nurses. And I think that the therapeutic relationship and being curious, but doing it in a really sensitive way, is where palliative care nurses and mental health nurses meet. It really is within that therapeutic relationship, within the therapeutic alliance. So yes, don't go in there and try and pull out their teeth. So mental state examination. So it goes through ABC, APC. So I'm just going to go through them ABC, APC as we go through. But that's an easy way of remembering it, ABC, APC. So we start with appearance. You're looking at self-grooming. You're looking at their general health. And sometimes people say, when we're going through our mental state examination, we start talking about appearance. We might be saying a dishevelled man who had a malodorous odour, and, you know, people think, my God, they're judgmental. You know, they're really, but it's really, really important information. You know, for example, if somebody comes in and they don't look like they've cared for themselves, their nails are bitten down. So you're actually looking, you're observing all that you can possibly observe. Is there stains on their shirt? Have they got makeup on if they're female? How are they carrying themselves? All those, everything that have they got a tattoo? Anything that you can pick up on. Things like, are they wearing way too many clothes when it's midsummer? You know, like they've got jumpers and they've got, I saw a delightful, I love this gentleman. I saw him out the front of GP Plus in Adelaide, which is a new facility, and it was nearly 40 degrees the other day. And he was there with his beanie and his coat and a whole lot of stuff underneath it, and his Ugg boots and shorts. And shorts. And it was 40 degrees. And you kind of know there's not something okay here. You know, there's something, yeah. So it's really important to note, what people are doing, you know, their mannerisms. So I'm going a bit too far away. Any marks that they have, birthmarks. As I said before, whether their clothes are too tight, too loose. You know, so everything you can, you know, are they looking their stated age? Like someone's telling you they're 50 and they look 75, really important information. You know, what's going on with this person. And their posture, their build, how they're walking, yeah. Can anyone notice what I'm doing today? Is anyone really observant? I've got a sore neck, so rather than actually moving properly, I'm kind of doing this. Yeah, so just really, really noticing everything and writing it down. Why would we be doing this, do you think? Why would we be so picky on what people are wearing, whether they've got makeup on, whether they've got a thing down the middle of their hair because they haven't had it dyed for a couple of months, whether, you know, why would we be looking at this kind of stuff?
Often for us it's a baseline
Yeah.
to see if, you know, if we're introducing any therapeutic treatment, whether there's a change in those type of things, whether, you know, that could be measured as an improvement.
Yeah. So you're saying it's as a baseline? Yeah, whether it can be improved. And that's exactly why we do it. I had the other day, I had this with GP Plus clinic that KG does, and there was this lady and she came in and she was absolutely flat in her expression, teary, only answered in monosyllables, didn't elaborate on anything, sat there. hardly moved. And I was really, really worried about her, I mean, her clothes were fine, everything was fine. I mean, she had a GBM, so she was no hair, but, and she was telling me that she was eating a lot, but she didn't have any appetite. And so I was really worried. Went back and spoke to the psychiatrist about her, and then went a day later to do a mental health assessment on her, proper full one on her. And there she was. And she was telling me jokes, drawing me funny pictures, talking about all sorts of things. Totally different presentation. So it was really important to get that. The baseline, I think, was around what was happening with her chemo. And she'd come out of it after a couple of days and was starting to behave, how she would normally do. So that's usually the reverse of what you see. Usually you see somebody who's really well-groomed, their hair's all shiny, their posture's good, and then 3 weeks later you see them and they're dishevelled and got stains on their shirt. But yes, it's exactly as you say, it's a baseline. So how does this change over time? And it really does reflect what's happening with this person's mental health. Yeah, so exactly. So that's the first one, that's appearance, and it's really important. So how does this person behave? Are they friendly? Like this lady, that day she was almost moribund, and then she was friendly, cooperative, helpful, offering me a cup of tea. That tells you a lot about what's happening with a person. Are they guarded? Are they hostile? Are they suspicious of you? One of the things you may see if somebody has schizophrenia is they may be kind of doing that, and they're listening to the voices. You can imagine that they can actually hear. They can't actually hear the voices. So they're kind of preoccupied, looking for where they are or listening to something else. So that's one of the ways we often tell whether somebody, if they seem to be responding to auditory or visual hallucinations. Are they calm? Are they calm, or are they moribund almost and not moving at all? Are they expressive in their gestures? So what's actually happening with them, and how does that change again over time? So all those things you note. Are they making eye contact with you? And again, it's really important. And again, you have to kind of consider, what background are they from? How important is the eye contact? I noticed I was sitting here this morning with the lady, and she was looking at me, and I couldn't turn around and look at her, So is it part of something that's happening physically, or do they not want to make eye contact? And that eye contact thing, I think, is really important. Can they make eye contact with you? If someone can make eye contact with you today and can't make it in 2 weeks' time, what's going on? Are they really depressed and they don't want to talk, or are they hearing voices that are telling you that you're the devil? What's actually going on for that person at the time? So you don't make a judge. You kind of put this in a whole picture. You don't make a judgment on one or two things. Conversation. So conversation, often people think it's what they're talking about, but it's not. It's things like what's their voice and speech and tone like. The lady I was telling you about, her voice when she spoke, it was very much in a whisper, so it's very, very quiet. Or are they really, really loud, like they're trying to talk over the top of the voices? Or are they talking really, really quickly? I mean, one way of kind of guessing looking at whether somebody is actually having a manic episode is they start to talk really loudly and really, really quickly. So have they got pressure of speech? Is it so important that to get this message across to you that their speech is pressurised? Again, it's a sign that somebody is suffering from mania. If they're talking quickly, their speech is pressurised, and it might be going all over the place as well, and they might be gesticulating a lot. So signs. So you're looking at these signs for different forms of illness. Do they have a good command of vocabulary and grammar? Often when somebody's had schizophrenia for a long time, they kind of lose their language abilities. They don't speak as well as they maybe did when they were 18 because of all that thought disorder that's happening. They start to kind of lose it a bit. Poverty of speech, like they're hardly speaking at all. And when they do, it's not particularly expressive. Again, that could be a sign that somebody's really depressed, or it could be a sign that somebody has, some kind of schizophrenic illness as well. So just noting all those things down. sometimes, and I'm going a bit all over the place, I'm sorry with the slides, sometimes when somebody's really depressed, that you might ask them a question like, what's your appetite like at the moment? And they might not say anything for quite a while. And you might think, did they hear me? But their thought processes have slowed down so much, and their ability, their motor skills and things have slowed down so much that it actually takes quite a while for them to actually answer you. So, having a conversation with someone who's severely depressed can actually take quite a while because it takes a long time.
When you're trying to document this in an exam, I work with adolescents and young adults with cancer, and sometimes it's hard to distinguish between sort of teenage angst and sort of economy of speech and sort of not even one word answers. It's often the parents are there, and that's sometimes I'm trying to think, okay, well, how can I contextualize this into their overall mental status, and it's something I struggle with.
Yeah. Well, yes. And I think, having a teenager myself, it's like, and they often go, huh? Yeah, and it's kind of, mental state examinations are across, you have to make changes for across the lifespan, really. So it's going to be really quite different for somebody who is a young person, and you just have to take account of that, really. And I'm not a specialist in that area, so there might be other things that they might, be looking for, in a young person. I'd be looking at things in a young person around their appearance. Would it be, their appearance might be things and like torn jeans and, hat on backwards and that kind of stuff. And in a mental state examination, I'd be writing down age-appropriate clothes, age-appropriate fashion, because it is, If they come in and their clothes are, they've got 10 jumpers on and it's all really mismatched and it's dirty, I'd be worried. So there's, it's kind of taking into account. Or if someone who was 70 came in with torn jeans and hat on backwards, it's like not appropriate, in the societal sense. So you're taking, and all those things you kind of have to really look at. Their social, it might not be just young people, it might be old people, it might be people from non-English speaking backgrounds. It could be also, and so taking that cultural element into it is really important. So yeah, good. I wasn't going to talk about that, so that's a really good point to bring up. It's really important to look at someone's culture when you're actually doing a mental state examination and making allowances for that. Yeah. Okay, so affect and mood. So affect refers to the various emotional responses witnessed during the interview. So are they teary throughout the interview? Are they laughing inappropriately? Are they laughing in response to voices? Are they... one of the ways I saw someone again at GP Plus the other day, and he had a wide range, is what we call a wide range of emotional responses. So when he was talking about his wife and feeling like she was going to be left with all the problems of the world, he was crying and really upset. When he was talking about his first grandchild had just been born, he was still, I'm not going to see this child grow up, he was crying and really upset. And then he was talking about the support he was getting, and he was quite calm, and then he made some jokes about things that were really appropriate. And so he really did have a very wide range of emotional responses to what was going on, and that's healthy to have that wide range of emotional responses. If somebody is laughing inappropriately, you really note that. If somebody, the only emotional response, like the lady I had, the first one I was telling you about, all she did was cry. So just noting all that down. Are they over the top as well? Are they responding emotionally to everything? Are they laughing and joking about everything? Are they almost histrionic about things they are talking about? Do they go from being really, really sad and then really angry, and then really happy in a really short period of time. Really important to note, because that's lability of mood, and that might be pointing to some kind of mental health problem as well. It might, they may have an underlying, schizophrenia. They may have some kind of bipolar thing emerging. So it's really important to kind of note, are they really labile in their mood? It might just be a bad day, So just noting that down. Are they irritable? Are they anxious? So they're the things that you notice in them. So you write that down, and then asking the person themselves, how's your mood been? How I usually how have your spirits been lately? How are you feeling today? Are you feeling happy, sad? And noting that down as well. So it's the affect and mood is really looking at, from a clinician's point of view, how you see that person's mood, and from that person, how do they see their mood? So you're looking at both those aspects, and do they match? If someone's telling you that they're fine and everything is well in their world, and they're sitting in a position that's really kind of hunched over, and they're looking at the ground, and is there a match in them saying they're well and fine, and their body postures and how they're talking? So that's the ABC. So A is appearance, B is behaviour, and C is affect and mood. And when I'm teaching general nurses, they're the main things that people are looking for, the ABC, in a mental state examination. However, then we go on, and we've got APC, and the other one's affect, perception, and cognition. So you've got, are they responding to hallucinations, delusions? Often I'll ask them if I think they are, do you hear voices at all? Is there anything happening there? Do you see things that other people may not see? I may never ask that question. It just depends on what's happening and how comfortable I am with it, because some people can respond, negatively to someone asking, do you hear voices? What do you think, I'm crazy? So it just depends, whether I feel comfortable in asking that question with the person. But yeah, watching out whether you can see that they're responding. And is there any other kind of... And the thing may be also, this lady that we were seeing the other day, she had a brain tumour, so there could be some disturbances in perception. And is that down to something that's some underlying mental health problem, or is that because of her brain tumour? So just kind of working out what's happening with that person as well at that time. Cognition. So this is the stuff that you would do a lot of, things like mini-mentals. Do you do many mini-mentals, looking at people's cognition? Yeah, so if I may not do a mini-mental, I may do a mini-mental, just depending on whether I have a concern about somebody's cognition. Are they orientated in time and place? Are they paying attention? Can they concentrate? Yeah, so that's, the normal thing you would do as a nurse anyway, is looking at that. How much is their memory intact? Can they remember long-term events and short-term events? Can they remember what they had for lunch? Can they remember what they had for dinner last night? Just those kinds of things, or are they actually better at long-term memory things? So very similar to what you would normally do. Looking at thought disorder, and this is in cognition as well, and that was one of the things I was telling you before about somebody who has a psychotic illness, schizophrenia, and sometimes it goes into bipolar schizoaffective disorder. And they may have things like flight of ideas, like ideas just coming and coming and coming and coming, and that often happens with people who have bipolar disorder and they're in the manic phase. Racing thoughts, circumstantiality. Everything, it's illogical and incoherent, like they might be talking to you about going to have lunch at dinner time. Things, it's just doesn't fit. It's all really illogical, and things don't fit together like they normally will when you're having a conversation with people. They may be really quite paranoid, like, why are you asking me these questions? And sometimes people might ask you why you're asking these questions anyway, but it's a way of doing it. Like, they might, well, why are you here? Why are you asking me this? What do you want from me? So are they paranoid? And is there any suicidal ideation? And I think this is really important, to note whether somebody has any suicidal ideation. And every time I've actually gone out with a palliative care nurse, they generally ask that in some form or another, if they suspect it. So delusions, looking whether they have delusions or not. And a delusion, I mean, we have to define it in mental health, is a belief that is not ordinarily accepted by the person's culture or subculture. And while the form of delusion proper is not understandable, it's often possible to emphasise with its content. So often what people will do is when they're actually working with people who are delusional, is they'll say, well, I'll say I'm blue, or, you know, I'm a pop singer or whatever. It's often a pop singer. They're talking, or God's spitting on my head, you know. And, you know, often the temptation is to say, no, God's not spitting on your head. I can see God's not spitting on your head. And then they'll go, yes, God is spitting on my head. So fighting with a delusion doesn't tend to work. But saying, oh, that must be really awful for you. You know, God spitting on your head, that must feel really horrible for you. You know, is that getting back into the feeling stuff, like you were talking this morning, Rob was talking this morning, about the rational and the emotional. It's really hard to rationalise with a delusion that's irrational. So just getting into that feeling content, I think, is really important. So you're going to get more information out that way, rather than fighting them about the delusion, actually empathising with them and asking them about the delusion and the feeling content is really important. So insight, so we've gone ABC, which is like appearance, behaviour, cognition, affect, conversation, affect, cognition, perception. And now we're going into two other things, which is insight and judgment. So insight is the ability of the person to understand their problems, their origins, and what can be done to overcome them. The degree to which the person understands they're unwell. And it's not an all or, you know, this kind of changes over time. So in mental health, it can be, do people actually see that they have, you know, a problem with their thinking or their thoughts or their behaviour? Do they understand that they have a bipolar condition or schizophrenia? And often they won't. But even though they don't believe that they have, you know, they believe you're wrong and I'm right about my behaviour, or what, you know, what's happening in my world, you know, my hallucinations are real and it's very hard to kind of change that. Even though they can see that their insight is not particularly good, the insight around taking their medication may be. So it's not all or nothing. You know, they may see that, yeah, I don't have a mental illness, you think I have, but I haven't. But taking my medication makes me feel better, makes the world around me better. So it's not an all or nothing phenomena. But somebody who has good insight into their problem is a sign that, you know, their mental health is chugging along quite nicely. Not their mental illness. And judgment, can they actually choose appropriate goals for themselves? Can they work out what's best for their family, best for their illness? Can they kind of make decisions? Can they kind of weigh up all the information that's given to them? If they can't do that, then you're kind of worrying about cognitive problems as well. And rapport, and I think for me this is one of the major ones. Are they able to establish rapport? Like the lady I was telling you about that was almost moribund in the clinic, she didn't establish, it didn't seem to me that we had established any rapport. There was no kind of connection happening there really. However, when I came back a couple of days later, she said, oh, hello. And she was really pleased to see me, so maybe we did. But, you know, that rapport, building that rapport is actually really important. Yeah. And if they can build rapport back, is really, really important.
That's an interesting point, Sharon, because I think sometimes one of the things that we try to do is establish a level of connection.
Yeah.
To ascertain whether, you know, we are able to help. And
yeah.
We might call it flat effect sometimes.
Yep.
So, as you said, you know, sometimes we might not be able to see this.
Yeah.
So I guess, what do we do with that? Because some people, you know, some of my colleagues or even myself might be a bit concerned
that you haven't established rapport. Your concern is that you don't establish rapport?
You feel that.
That you feel that you haven't established
rapport.
rapport.
That rationally, those elements contributing to that not happening. Yes, and then it's encouraging to hear you saying, you know, a few days later.
Yeah.
And it has happened, but sometimes it's that level that I think we grapple with.
Yeah.
Because, you know, we relish and we rely on the immediacy of rapport in palliative care practice sometimes.
Yeah.
And I think we need to feel comfortable too saying that we're not the right person for this person. You know, sometimes I've met people who clearly, you know, there might be just one point that we just haven't hit it off on, and you know, so sometimes it is about going back to the team and saying, look, you know, I don't think I'm the right person to be involved with.
So knowing when you've established rapport, knowing when you've established rapport or not able to.
And when you think that it's not going to be established either, you know, because sometimes it can just be something simple like you're late or something like that for an appointment, and that just really sets people off, and it's really hard to bring that back sometimes, isn't it?
Yeah, and that's something that I've come across a fair bit, thinking that I haven't really developed much rapport with somebody, and then I find out that they think we have, you know. So, yeah. Okay, so just one of the things that people often, well, what do you do? You know, what's the most important thing from a mental health perspective? And I think it's the same in palliative care as the same is in mental illness. And Tainahan, who's a Zen Buddhist monk, I think said it really, really nicely. And he says the most precious gift we can offer others is our presence. And I just want to briefly touch on risk assessment. Risk assessment, I think, is really important, looking at things like, for your people, things like suicide, but I'm going to look at risk in general as well. So things like warning for suicide. Normally I'd ask you this, but I think a lot of you would know this anyway. So loss of interest in pleasurable activities that they found before, they found pleasurable and now they're not finding pleasurable anymore. Problem behaviour. So again, this can be a problem if someone's a teenager and they're experimenting. It might not be part of it, but you've got to kind of take this in context, and several of these signs, not just one maybe. Problems with behaviour and substance abuse. Apathy in dress and appearance or sudden change in weight can be a risk sign. Withdrawal from friends and social activities. And with young people, that's one of the things I'd be really concerned about, is if they're quite socially active and suddenly they started hanging about in their room and not going out. That to me is a risk thing. It might not be for somebody who's older and wanting some space on their own. So you've got to put it in context. Or somebody who's just been diagnosed and they need some time to themselves to work things out. Sudden and striking personality changes. So somebody who's been really quiet and shy and they've suddenly become really out there might be a warning sign, or the reverse. So any kind of sudden personality changes can be a concern. Increased accident proneness or self-harming behaviours. So people who, you know, aren't paying attention to what's going on around them and start having accidents. Self-harming in itself might not be a risk factor for suicide, because often people who are distressed, I mean, there is a high level of people who do things like cutting, people who haven't got identified mental health problems, cutting, doing all sorts of kind of self-harming behaviours. But it's one of the signs. And the one that you might be seeing is a lot of expressions of hopelessness, helplessness, despair, sense of shame or guilt, changes in eating and sleeping habits. Again, with young people, that's one of the things I'd be really worrying about. If somebody, started sleeping, young person who wasn't sleeping much at all suddenly started sleeping a lot, or vice versa. But the same with anybody, but that's one of the ones I watch out with young ones. A severe drop in school or work performance. So somebody who's chugging along really nicely at uni or at work and suddenly it's dropped. That's and especially for people who are in the work environment still within palliative care and suddenly they just don't want to go there anymore. And what's the point? What's the point in going to work? What's the point in doing anything properly? The biggest one I find for a risk for suicide is a lack of interest in the future. And all these things like we were talking about before are indicators of major depression, but they also can be indicators of risk for suicide. If anyone tells you that they're thinking about committing suicide, that's a huge risk factor. Like not, in Palliative you get the kind of fleeting stuff, oh God, I wish I was dead, I don't want to go through this, I don't want to go through the pain. When somebody's starting to talk to me about that, I kind of, have you ever thought of harming yourself? Have you ever thought of doing anything that might, cause you harm? Do you ever feel unsafe? Do you ever feel like you might do something to hurt yourself? And if they say yes, it might be asking them things like, do you have a plan? Have you thought about a plan? Now, if they've thought about a plan, then I start to get really worried, Then asking them, well, what is your plan? Do you have the means to do it? So just asking all those questions, I think, is really important. So giving notice or saying they're going to commit suicide, taking it incredibly seriously, and giving away possessions and putting their affairs in order. I had one lady and she had a brain tumour and she didn't particularly want to go on with it, but she had 5 animals, I think 3 dogs and 2 cats, and she couldn't, and she gave them away. Yeah, really worrying. So, and like the other lady that I saw the other day, she gave all her animals away because she wasn't able to care for them, but all the other risk factors weren't there. But this lady spoke about having plans and, spoke continually about, not wanting to continue on and gave her animals away. So again, putting it in context. So one study calculated that 72% of people who make plans then go on to make a suicide attempt.
So just with those warning signs, are some more weighted than others? So like would you sort of look at one and say, okay, well that might be in itself might not be an issue, but then they had 3 or 4, you might think, or...
there's no, calculation around it, but I'd be looking at how are they feeling about their future? Are they looking forward to their future? Do they have any pleasure in their life now? So future pleasure in their life now. Another one is, have they had a suicide attempt before? Has anyone in their family close by, has their mother, father, brother, sister killed themselves? They're high risk things. Do they have a substance abuse problem? If somebody's got a substance abuse problem, they may be talking to you and they may be quite sober, but they might then start taking their drugs and it's quite common in that situation. So they're the main things. I mean, is there a history of suicide? Is there a history of family suicide? Lots of pleasure in anything. Giving away possessions is one. Putting their affairs in order.
One of the things that I always find difficult is that a lot of what you've said in especially the major depressive, the anxiety and all of that sort of thing, we see every day.
Absolutely.
In most of our patients. Yep. A lot of them have lost interest, a lot of them don't have much hope for the future. Yep. And sometimes it's difficult to know when you might need to instigate. Have you got enough time to instigate an antidepressant? Exactly. They're already taking 10 tablets in the morning and 10 tablets in the afternoon. And so a lot of this is what we see every day. So that's where I find it difficult sometimes is
where do you tease out
knowing when to treat it, or is it normal? I'm sure if I was dying I'd probably feel that way as well. So.
Exactly. It really is difficult to tease out. And for me now, having been in palliative care for 16 months, it is things like, is that mood constant over a period of time? And you might not have the time, you might only have a couple of weeks. So instigating an antidepressant, which is going to take at least 10 days to kick in, that is difficult.
They do say that some antidepressants like mirtazapine and that have an instant sort of effect on sleeping,
appetite. So if that, for me, that's the drug of choice in Palliative, is the mirtazapine, because of that, and also it can give them a feeling of well-being, in the appetite and sleeping, and so I'd be thinking that way.
We grapple with this a lot with our suicide prevention, the protocol that we have in our service, because this is a bit tricky in terms of what elements do you put together that will become, a risk assessment for people who might be at risk of suicide, which we do encounter. Yeah. And what you said, Sharon, is that, I've seen that when they really talk about the plan, that there might be a plan.
There's a plan.
And yes, and all of that, then again, the conversation with the interdisciplinary team, what's going on here, but and we have had a couple of, in the number of years, two suicide attempts.
Yeah, I think in those situations then you've got to minimise as much as possible them actually carrying it out. And I just think about the guy I had with him at motor neurone disease who was still very mobile, but he was a diver and he had his tanks in his room, and he'd always said that he was going to have his nitrous oxide or whatever it was in his tanks these tanks were sitting in the bedroom next to him, So I said to his wife, you need to take them out, you need to get rid of them, you need to put them out of his way, don't allow him access to, she was worried because every day he'd do, who I'm talking about, every day he was saying, I'm going to, do it with the tanks. I don't know what they were or what effect, anyway. And so I said, look, he can get them while they're there, don't let him. So then, it's about reducing the risk as much as possible. You can't always prevent, but you've got to make an attempt, I think, to, to actually not allow, not assist them to carry it through, to try and reduce it.
We often, in our region, I find it hard for the psychiatrists and the CAT team to take it seriously when they're palliative care patients. Where we had a youngish woman who I saw at home who was suicidal, had a plan, had it all mapped out, 3 young children in the house, and actively talking about killing herself. And so ringing the CAT team, and they're saying, well, she's palliative care, we can't come and see her. And we ended up getting her into our palliative care unit and getting a psychologist to see her, and was discharged 10 days later and killed herself that night. But the psychiatrists didn't have time to see her. They sent the psychologist. There was really, this is a palliative patient, and just didn't seem to engage because it was palliative, which I found really frustrating, especially when she did carry it out.
Yes.
On discharge.
It's a tricky one. I think there's a lot of work to be done with mental health services because they don't understand the merging of mental health and palliative care. There's very little research done on, and saying from my mental health, everything is about recovery and getting better. The entire focus is on that. And so you have someone who's palliative, well, hey, and I don't know what it's like here, but in South Australia, death is not something you talk about in mental health. It scares clinicians witless. You just don't, So they don't want to know because it's too scary. So there's actually a lot of work to be done around it in mental health. Yeah.
We had a similar thing too, that the person did have a plan. We admitted her because the CAT team wasn't about, not the same, but similar response. Went into an inpatient setting, was there for a few days, came home, and 2 days later she threw herself to the drain. So it did, those are the things that...
I missed the other high risk. I'm really sorry. The other high risk is a serious physical illness. So you're actually in the category. Yes. Yeah. So I, as my mental health nurse, missed it.
I think that's what's been really helpful in our service, that we have psychiatrists as part of our service, so we can, and this triage process of actually asking people at the time of referral to the service, have you ever had any mental health problems, and then being able to track back and get a history of those, so that it's about being prepared rather than finding out down the track that
that preparation is really
it's about how you engage mental health teams into your palliative care.
But often patients won't disclose that because they see mental health illness as a stigma.
They do once you start asking the question. I thought that if you asked me 16 months ago, I said people don't admit they've got a mental illness, but You know, they do. They're very, very, you know, they want you to know about it, you know. It's surprising once you start asking, you know, like you say, have you got diabetes, a heart problem, have you had any mental health problems? You know, you use it as part of your asking about comorbidities. They will admit it. They'll say, yes, I actually did have a breakdown, you know. And then gives you the chance then to get a little bit more history on it. So just start asking the question and see how you go.
As normal.
It's part of our normal.
As normal. Have you had asthma? Have you had high blood pressure? Have you had a mental health problem?
Normal. You're right. Right. When you say, have you had a mental health illness? People often perceive that as schizophrenia or that. No, but if you say, you know, have you got any anxiety problems or that type of thing, they'll disclose more then rather than do you have a mental health illness?
Yeah, exactly. Sorry.
It's also the people that have to recognise that they've got one. Like I've done a lot of, I've worked a lot recently with our PAPS priority assessment team once, and the carers have, you know, quite clear psychiatric issues that have never been diagnosed.
I know.
And you ask them that question, and they give you the why do you think I'm, you know, and then all of a sudden you're offside and that you're paranoid. And we've actually had one of those kept a body in the house for 14 days. Told us he was going to do it too, but very, very difficult. Very difficult.
And actually, through this project, one of the things we found out was that carers are probably more likely to have the mental health illness than the patient. And you know, and it's another project that we have to do now, really around carers.
I know. How often you hear there is an undiagnosed. You know, because it is a major issue because it compromising the care and all of that.
Absolutely.
And the services are better in Victoria, but they're still fragmented in many ways. And I can imagine in the rural area, Regina, even more so.
Well, getting access to a psychiatrist in some of the rural areas in our region, some areas psychiatrists will never visit, other areas they might visit every 3 months. So they say, we'll send them up to Ballarat, and it's like, well, it's a 5-hour drive and this patient is, you know, palliative. So a lot of the discussions over the phone, or we're having to do it as the consult team and trying to work with the GPs.
Yeah, I think the invention of e-health will be very helpful with that. Because I come from a country where e-health was done 20 years ago, so it's still a developing stage here. So you tap on the internet and you see the whole record from every GP that person has been visiting, every health professional who has been involved. So you're not likely to miss about these things. Also, if someone is discussing euthanasia, the wish to die, overseas there's a whole system in place that when someone expresses that wish, that the whole team comes into action to actually do psychosocial assessments by 3 different specialists to see if that wish can be granted or if we can work around it. So I think e-health is going to be quite exciting if it's done properly.
Absolutely.
And Australia-wide as well. So that was my idea.
Absolutely.
Yes.
It was one of the things we tried to do through our project but we couldn't find the technology to do it at the time. The safe technology was about the, you know, telehealth, using telehealth to do mental health assessments over the, you know, getting the client in the country and our psychiatrist and trying to tee that up, but we weren't able to achieve that part of the project because of the technology wasn't available. But
one of the things we've got in the project, we were really lucky, the mental health system in South Australia has a mental health database, so that anybody who's even made a phone call into mental health over the last 15 years, it's there. And the only people who have access outside of mental health is Southern Palliative Care at the moment. So, and we got special permission for it. So, and it's really, really helpful to know, you know, that and what medication they're actually on, because often, you know, people are taken off medication or they don't know that they've been on psychotropics or whatever, you know, and it really does affect what's going on with that person. So it's really important that we have that information.
There's a major project undergoing at the moment from the federal government about the issue and the e-health component across Australia.
Really?
So I think it is looking more promising than it ever did before.
I just wondered if you could comment on when you would perceive the need for a psychiatrist over a psychologist? And
Yeah. It depends what the psychologist actually is trained in, and what their background is. But so, for example, one of the psychiatrists that's currently working in mental health, who's been trained in severe persistent mental illness, and that's where they're working and that's where their focus is, I'd draw on them probably about as much, other than around medication issues, because the psychiatrist knows the medication issues. But generally, taken that away, taking that the psychologist working in mental health away, taking just generally psychologists over psychiatrists. Psychiatrists really do understand what severe persistent mental illness is. They do understand everything that we've been talking about. They're absolutely brilliant at doing mental state assessments, and then managing and working with that person, complete episode of care kind of stuff. A psychologist may know nothing about any of this. It just depends on what their focus is. So a psychologist might not even know what a mental state examination is. So it just depends where their focus is.
They might be therapy based.
There might be therapy based. There might be cognitive behavioural therapy. They might be, So it just depends.
Or neuro.
Yeah. There might be some other area entirely. So it's important to find out. And anything around medication, psychiatrist, and comparatively.
So you tend to work with a psychiatrist now?
Yeah, we're really lucky. I think Southern Palliative Care is the only one in South Australia that has a psychiatrist. I don't know about the rest of the country, but she's been there for about 6 years, and she's brilliant. She's really great. So she's really specialised in, the crossover between palliative care and mental health. Yeah, and really looking at medication issues as well, because it's quite complex.
She did a fantastic presentation at the Palliative Care Australia.
Yeah, she's great.
She's great.
She's really
what is it called?
Dissociated. Discontinuation syndrome.
Yeah, syndrome. Yeah.
It was very good.
Because that's something that we've really been very slack at in palliative care. Just stopping a lot of these medications.
Stopping venlafaxine.
People can't swallow and not thinking
it really
about,
made me think, about
things like venlafaxine that you can't just stop.
She'd actually
and how do we, and we just had a lady, on clozapine, and we were quite concerned about, and she actually had, esophageal cancer, so she had difficulty swallowing, and we were just always one step ahead of that though, weren't we? We planned all the way along how we were going to manage this, because only certain psychiatrists can prescribe clozapine. They have to be clozapine prescribers, and this lady was no longer able to get to a psychiatrist, but we would do it. So Karen would go and do the assessment, ring the psychiatrist, and the ordering would all be done over the phone, but we were prepared for that. So it didn't sort of come as suddenly she can't swallow, what are we going to do?
So there was a plan. I mean, what could have happened is, one, she could have just been taken off the clozapine, because she's dying, and then we've had that experience of people coming off the clozapine, they're dying, and they've actually been stable for many years, and they've died in a psychotic state, so really important. But this, I think, because of Karen and because of KG, and understanding, the importance of clozapine. I mean, going in there first, checking that the nursing home is still giving her the clozapine, because it's, it has to be prescribed and gotten in a certain way. And then, okay, this lady is now in the terminal phase. What are we going to do? We can't get it across to, her psychiatrist anymore. It was really good. The psychiatrist was up to speed on it. The treating psychiatrist, the other one, was up to speed. And he was quite willing to go out and see her, but he couldn't. So, we teed up in the morning that the day before she would have her bloods done, that morning the nurses would do her, OBS, and then, she would be assessed by the psychiatrist. And it was quite complex to actually organise all that, but it meant that she died in a really planned way and not in a psychotic state. And everyone pulled together with a lot of goodwill around that. But not many nursing homes know, or even GP, don't pull her off the clozapine. So there's many medication issues around, mental health and terminal phase or mental health. And
so how was it given in the end?
Orally. She still had it
when she couldn't swallow.
She didn't get to that phase. She died before she actually got there, but she got her clozapine. So
what if you had a phase of a month of not swallowing?
We kind of.
She'll come back.
That is the problem. That's where there needs to be. There isn't any replacement for it.
Olanzapine wafers and things.
But
like
even
that.
so, clozapine is given to people who are treatment resistant. So all the other psychiatry, they only give it. This is the last drug we can actually give. So, olanzapine probably hasn't worked in the past. So you've got there's no equivalence. So, it needs to be really looked into. What do we do when people can no longer swallow and they're on things like clozapine where there isn't some kind of equivalence?
As anticipatory practice, because we did have a similar problems, we did try again olanzapine wafers, but they weren't as effective because there was an issue where someone, we can be very readily to de-prescribe without really seeing the implications. Where we had someone who had, a bad psychotic episode in the terminal phase, and that was not very for the family and for the client.
Horrendous, really. What a way to go.
And it was that eagerness, to de-prescribe without really seeing the implications.
Yeah, exactly. Yeah, people are on clozapine because, and it's such a serious drug anyway. It's monitored nationally. You have to have a blood test to have it once a month. You can't be prescribed it, before you've had your blood test. And it's so closely monitored because of the side effects. And so people are on it. It's a serious thing. You can't just pull someone off. And yes, there is now, at the moment, no equivalence. So what do you do when someone can no longer swallow? So we were having really bad, what are we going to do? What are we going to do? And she did die before that actually happened. So.
Oh, that was a blessing for her.
It was. Because the toxic dose is so close to the therapeutic dose, so you just got to sail close to the wind the whole time.
Yeah. And she's losing weight.
She went from like 200 something down to 50 or something.
So then it's going to affect the dosage as well. So
the dose just went down and down and down until almost she was on
20 milligrams.
20 milligrams,
which is nothing otherwise.
So, that was,
I think I've got one more. I just want to talk just slightly, and this is my last one, about other forms of risk, because quite often in mental health we just think of risk as suicide. We don't look at other forms of risk, and I think that you guys actually do, and there's things like risk of self-neglect. Somebody's got a mental health disorder and they're not looking after themselves. So and this is sometimes can be really hard too, like, your experience with a mental health team not coming in. Somebody's not, because of their mental illness, is neglecting their physical care and deteriorating. That's risk. They're being sexually abused by others, of course that's risk. They're being financially abused by others. And a big one in mental health at the moment is heat risk. People who are on particularly antipsychotics, it cannot be out in the heat. They get dehydrated really quickly and can die really quickly because of heat. So it's really important when somebody's on antipsychotics to actually be aware that they're in air conditioning, that they're not going out into the sun. And cognitive disability. And the only reason I'm mentioning these is quite often people, when they're thinking about people with mental illness, think about things like suicide. But there's all these other risks as well that I think is really important to take note of.
I just had a question regarding consent. With people with mental health issues. Often there's increasing cancer treatment offered to people in the palliative phase of illness, and we kind of interlink of the treating oncologists, and you see people who've got histories of long mental health issues, and you're not sure if how well they've been informed about the treatment or how well they've understood the treatment, and where does it stand in terms of informed consent?
Exactly.
Because I guess sometimes there's a one-size-fits-all approach to consenting people for cancer treatment. This is going to be good for you. This is it, but without glossing over perhaps of some of the side effects. it's a difficult issue, and sometimes it's a risk that they're not understanding what they're up for.
Yeah, there's two things about that. One is that there's been a lot of research, a little bit of research done by one person, which is a lot. A woman called Foti in America, Elaine Foti, has done a lot of research on consent with people with severe persistent mental illness, because there was the concern that, people who had schizophrenia, people who have schizophrenia and they're stable, of course, their judgment is as good as anyone else's often. But somebody who's psychotic or whatever, she's done a lot of work around consent in that circumstance, and they found that people were really able to consent as long as you gave them a scenario. They did it in a different way. They didn't just say, if this happens, that happens, what would you like? They gave them stories, told them stories about scenarios, about things that would happen. And in that scenario, what would you like? What would you like in that one? So they were able to give consent, but you had to actually work at it a lot more. But Elaine Foti has done a lot of work, so she's really good to look at. Another one is in our guardianship board, John Brayley, who's the director of Public Advocate at the moment in South Australia, he's been looking at a continuum of consent or supported consent, so that it's not an all or nothing thing. That ability to consent may change over a period of time depending on somebody's mental state, because they might get better or get worse, but also that they may be able to consent to some things and not others. They may understand some things and not others. So getting somebody to support them. So the guardianship board may actually have somebody that gets to know this person really, really well, that gets to know what their beliefs are, what their values are. So working with that person's values and then trying to tease out what they would like, and whether that, from their own philosophical value base, whether that would fit. So, and it's a gradient thing, it's not an all or nothing thing. So around mental health, it's starting to look at not black and white, but a continuum. Yeah. And he's done a lot of work as well, and it's also up on the website around that. Yeah. Any other questions, thoughts? Thank you.